Hello, my name is Sam Ord. I'm an ICU doctor at Nepean Hospital in Sydney, and this is an introductory lecture on focused cardiac ultrasound. During this lecture, we will be discussing the role of focused cardiac ultrasound in the clinical setting and some of the important limitations there are to this examination. We'll be discussing the relatively simple process of consent and also the importance of describing the study to your colleagues. We will discuss the care of the machine. These are an expensive piece of equipment and they need to be looked after appropriately. There are some safety issues to discuss, as well as what to do with the images once you have taken them, in terms of looking at them and analysing them, as well as storing them. Finally, we'll discuss the potential areas of credentialing that you can do if you wish to get a formal qualification in this subject. And in particular, I will discuss a little bit towards how this relates to the Australian and New Zealand College of Intensive Care Medicine, because focused cardiac ultrasound is now a mandatory part of the training curriculum. The role of focused cardiac ultrasound in clinical practice is a powerful one. This examination can be used for making essential diagnoses such as tamponade, diagnosing significant left ventricular or right ventricular dysfunction. It can also help in assessing certain cardiovascular physiological statuses, such as significant hypovolemia, for instance. It can reduce diagnostic uncertainty, but it's not perfect. And in this regard, I try to explain that focused cardiac ultrasound is a little bit like an extension of examination. And it can facilitate decision making, but it should be noted that we try to use focused cardiac ultrasound to answer questions in a binary fashion. The answers are yes or no. The questions that you want to try and answer are to try and assess gross size of the left ventricle and systolic function, the gross size of the right ventricle and its systolic function. Is there a pericardial effusion present? And if it is present, are there echocardiographic signs of tamponade physiology? We can use it to estimate fluid responsiveness, particularly at the sort of severe ends of the scale of significant hypovolemia or significant hypervolemia. And it can also be used to try and detect some gross signs of chronic cardiac disease. Focused cardiac ultrasound does not provide all the answers, unfortunately. I think when I started off learning about ultrasound, I thought it was going to be the answer to everything. And some of my diagnostic uncertainties were going to disappear forever. And unfortunately, that's simply just not the case. Anyone who's examined a critically ill patient would know they're extremely complex, and ultrasound is not going to answer every question that you have about them. Focused cardiac ultrasound does not involve Doppler. For me, Doppler is as part of intermediate or advanced training in focused cardiac in ultrasound. And I hope to be able to teach you some of that, but it's important to learn to walk before you can run. And the limitations that we're discussing in focused cardiac ultrasound, there are absolutely even more limitations when you're involved with Doppler ultrasound. So again, it's important to know some of the fundamentals before we branch out into Doppler. Focused cardiac ultrasound does not rule out cardiovascular disease. There's going to be a tendency when you start to learn this, and has been shown in several studies, that there's going to be a tendency for you to overcall things when you start out. And there's going to be a tendency for you to miss pathology completely. And that's why it is important to remember the limitations of your studies, and you are not able to rule out cardiovascular disease. In sort of follow-on to saying that we don't use Doppler analysis as part of focused cardiac ultrasound, it therefore goes that we cannot use these studies to try and determine valvular function, assess diastolic function, or estimate intraventricular pressures. What I hope you will be able to do is maybe by the end of the study period to know what a significantly calcified aortic valve looks like with its pore opening. But again, it's not about assessing valvular function. It's just about assessing valvular appearance. And finally, focused cardiac ultrasound does not, unfortunately, precisely determine intravascular fluid status. Nothing is perfect in this regard, and ultrasound is unfortunately exactly the same. It can help you. It's maybe more accurate than clinical examination, as some studies have shown, but again, it's not perfect. In regard to consent for doing a focused cardiac ultrasound, I think it's important to introduce yourself to a patient just as you do every time you examine them, and that's whether they're sedated, ventilated, or awake and talking to you. I think it's important to try and get verbal consent if you can for doing this procedure, and it's important to let them know that if you are training in focused cardiac ultrasound, that these studies are part of that training process. And in that regard, it's also really important to try and let the medical and nursing staff who you're working with know that you are doing a focused cardiac ultrasound exam. When I was learning, I'd often see that maybe one of the nurses had written in the notes, echocardiography performed. And I think it's important to reiterate again that you're doing a focused study, that you're answering binary questions. This is not a complete study. As I mentioned, these machines are expensive and they've got to be looked after appropriately. Some machines are more robust than others, and some of the transducers are more robust than others. But there are delicate components to this that need to be looked after appropriately. In particular, the transducer themselves with the piezoelectric crystals that are an integral part of the machine, as well as the cables. And it's important that you pick up the cables after you've been using it or when you're about to use it, and you don't run over the cables with the wheels of the machine, because that will break them and then you're not going to be able to do your study. When you're doing your studies, it's important to attach the ECG cables. Even in these emergency scenarios, it can be important to come back to try and figure out at what stage in the cardiac cycle you're in. And that's why it's important to have your ECG at the bottom of your image so that you can help determine that. It's important to record and enter your patient details, because when you're going to want to come back and analyze these data, and in particular if you're going to want someone to review these at a later date, even if it's that day or in months to come, it's important to have the data available and know how to find it. In terms of after you've used the machine and when you're using the machine, it's important to care for it appropriately. And that involves, of course, cleaning the machine after you've used it. In particular, if you've been in areas where there are infectious issues, cleaning the machine appropriately is important. Now, different machines have different cleaning products that need to be used on them, and some of them can cause damage to particularly like the covering to the transducer. So it's important to know your machine, know how to clean it, and look after it appropriately. There are a few safety concerns to consider. Firstly, to the patient themselves. We're going to be talking about positioning the patient, and often we like to have them rolled onto their left side, and it helps move some of the lung away, helps move the heart closer towards the chest wall so that it can help with imaging. In particular, if your patient is intubated and you're moving the patient around, you need to make sure that someone obviously has got protection of the airway, so you're not extubating the patient inadvertently, but also making sure that you're caring for the patient, and if there are fractures, for instance, you're not moving a patient who is significantly hemodynamically unstable if you shouldn't be. Secondly, for a patient's safety, it's important to know that there are no epidemiological studies or any other studies that have shown that ultrasound at diagnostic intensities can cause harm. But there are studies that show that it is not inconceivable. These are studies that are mainly done on plants or in vivo or animal studies. And this is where this principle of ALARA comes from, which is as low as reasonably achievable. And that means that you don't sit there with the probe on someone's chest in the same position for an hour. You try to make sure that your studies are clinically indicated and that they are as short and succinct as possible. But again, I reiterate that ultrasound is a fantastically safe tool, and there are no reported side effects from ultrasound at diagnostic intensity. And that is one of the reasons why it is potentially so useful in the critically ill. Lastly, try to remember you've got to try and avoid injuring yourself as well. If you're going to be doing lots of studies, you can get shoulder damage. Sit yourself down and try and get yourself in a comfortable position when you're doing your studies, if that's what you like. If you are moving patients around, make sure you don't hurt your back. Just try and think ahead, because if you do a lot of imaging, there is musculoskeletal risk involved for you as well. So once you've got your image, I encourage you to try not to form the conclusions without going back and looking through the whole study. It's often not straightforward, and sometimes the imaging is not as easy as it looks in the textbooks. And I'll try and take you through a lecture where I try and show you how to get the best imaging you can, but sometimes you just sort of catch the one cardiac cycle that you can, you just sort of quickly grab it. And you may think that you've got the worst study that there is and you can't make any conclusions. Well, I encourage you to actually look through the whole study and review it once you've taken the images, and go back to the start and look through it again, because often you're going to have better sort of images and the better ability to draw conclusions than you think. Once you've reviewed your image and you've formed your conclusion and you've written down your assessment, it's important obviously to store the images. Now, sometimes your facilities aren't going to have a storage facility, in which case it's going to be up to you to store them. Often we can't, there's a limited amount of storage capacity on these machines, and you're going to have to take off your images. There are many ways to store different images, but the most basic way that any machine will be able to do is storing it in something that's known as a DICOM format. And this is the most basic way of reviewing an image. There are many free softwares available on the internet which you can download so that you can view these DICOM images. I think it's important to say that I think anyone who's been working with computers for long enough is going to have lost data at some stage. Just try and ensure that you've got a regular backup of your images, because it's heart-wrenching when you lose a whole bunch of studies. There is a very important patient confidentiality issue, of course, which is if you are going to be storing these images on your computer, you have to try and make sure that they are protected, the data is protected, and that you, if you are not going to do that, that you de-identify your images. Now, if you are transferring data in this DICOM format, sometimes these images can have patients' details hidden in them when they are transferred. It's really important that you try and make sure that if you are anonymizing the data, that you do it sufficiently. And in particular with accreditation, we're going to talk about transferring data for experts to review. If you are going to send data to accreditors to review, and these accreditors are not directly involved with that patient, you have to de-identify the patient's information. So, as I said, there are some significant limitations with focused cardiac ultrasound. And when you start off doing these studies, you are going to overcall things. And you are also going to miss things completely. And in the same way as if you are looking at a chest X-ray or a CT, you've got to know your limitations. You've got to know at what stage you are on that spectrum of training between someone who's a complete novice to someone who is an absolute expert. You've got to have an idea of where you are on that spectrum and the accuracy of your conclusions that you're drawing. I guess I'd also like to say on the flip side that I'd like you to, you have to try and make some conclusions though. Actually put these into clinical practice. This is a fantastically powerful and useful tool, I believe, as long as you've had sufficient appropriate training. And probably the most difficult thing I find isn't teaching people how to do this imaging, it's what to do when you've got the results. And that's why it's important that if you do see some abnormalities, you discuss it with a senior who's used to looking at echocardiography images. And also, if you do see abnormalities, it's really important to consider that a formal echocardiography examination should be done, because as we've mentioned, there's going to be a tendency to overcall things, and there's going to be a tendency to miss things altogether when you're doing a focused cardiac ultrasound examination. So finally, let's talk a little bit about credentialing. Some of you are going to want to have a formal qualification in this, and there are many different ways of doing it. In terms of the Australia and New Zealand College of Intensive Care Medicine, we developed a training program that was based on expert opinion on what it takes to become trained in focused cardiac ultrasound. And that typically involves attending a 1 or 2 day training course that has a significant component of hands-on training as part of that training day or 2 days. After that, you should go away and should do 30 studies, which are reviewed by an expert in echocardiography, and then finally do a short test or a short exam to show that you are able to assess images appropriately. And that's it. At the end of that, you are considered proficient in performing a focused cardiac ultrasound. What you do with the images and the conclusions that you draw, as I said, is a little bit more complicated, and that takes a bit more time. But it's just 30 studies and attending a short course and doing a short exam, which is easy, which will get you over the line to be able to integrate this into your clinical practice and make potentially sort of diagnose life-threatening abnormalities. We based the focused cardiac ultrasound curriculum for the College of Intensive Care Medicine on the CCPU, which is a certificate in clinician performed ultrasound, which is part of the ASUM, or the Australasian Society of Ultrasound and Medicine. Now, if you do wish to try and get the formal CCPU qualification, you just have to do another online physics component and do a few more exams in terms of having them reviewed by an expert whilst you're actually doing them, live exams. And then you can gain your certificate in clinical performed ultrasound. There are many other courses. They will be put onto the College of Intensive Care Medicine website, and they're all good at this level, I think. I've done several of them, and I can't recommend them highly enough. They're all of a similar standard, and they're all very good. But it's really important to remember that I don't think you can become competent in focused cardiac ultrasound without regular hands-on experience and having some form of mentorship with someone to be pointing you in the right direction to make sure you don't get into bad habits, and making sure that you continue to know your limitations but have enough confidence to try and integrate the findings that you see into your clinical practice. So the focused cardiac ultrasound consists of doing 4 main views, and that includes the parasternal long axis view, the parasternal short axis view, the apical 4-chamber view, and the subcostal view. You can include the apical 2-chamber view as part of your study. I don't consider it an absolutely fundamental view, but it is obviously very useful, and certainly if you wish to get into more advanced echocardiography, then it does become essential. But for me, it's not an essential part of the focused cardiac ultrasound study. With these 4 views, you can then answer the binary questions. Do the ventricles look abnormal in size? Do they look grossly dilated, normal, or small? Is their function normal? Do they look hyperdynamic, or normal, or mild to moderately impaired, or significantly abnormal? Is there pericardial fluid present? And if there is there echocardiographic signs of tamponade physiology? And we should be able to make some fairly basic estimates of what the fluid status is and whether your patient would be fluid responsive or not. And I think that is best at the extremes. And in the middle zones, which is probably unfortunately when it's most clinically relevant, I think a focused cardiac ultrasound has some significant limitations. So the binary questions, to repeat, of what you're trying to find out is there normal or grossly abnormal LV function? Is the LV size grossly abnormal, yes or no? Is the RV function normal or grossly abnormal? Is the RV significantly dilated, yes or no? Is there any pericardial fluid or tamponade physiology? Is the patient significantly hypovolemic? And finally, and probably most importantly, is trying to form conclusions that address the relevant clinical question. Finally, I'd like you to try and remember that if no abnormalities are seen in your focused cardiac ultrasound study, you must discuss them with a senior clinician. You must consider a formal echocardiography examination. It's important to remember that focused cardiac ultrasound is not about ruling out cardiovascular disease. It is about trying to help in your differential diagnosis formation. It is about trying to diagnose potentially life-threatening abnormalities. And it's about trying to use the focused cardiac ultrasound as an extension of examination. And in that regard, of course, it's not going to have all the answers, but it can certainly help point you in the right direction. It's really important to know your limitations and where you are on that spectrum of forming conclusions, and have respect for, if you are at the basic end of the spectrum, have some respect for the complexity of echocardiography and try to understand some of the limitations that are involved. And I guess most importantly, keep learning. This is a tremendously powerful and useful tool, I think, and it can become very complex, obviously, but I think it is very useful, and particularly in the focused cardiac ultrasound setting with relatively little training, I think you can get a lot out of it. So, best of luck with that. Here are some of the references for some of the articles that were used in forming this lecture, and I wish you all the best. Thank you very much indeed.